and he'll be showing his thesis showcase. His thesis was on AI and ANA patterns. So, Doctor, over to you, Dr. Harsh. You can start your presentation. Time allotted is for 15 minutes maximum.
Uh, Thank you, sir. Thank you, sir, for the opportunity. Are my slides visible, sir?
Yes, yes, yes. You get
Yes.
it into the
The
slideshow.
PowerPoint. Yes, the
Yeah,
PowerPoint models.
yeah, yeah.
Okay, sir. So good morning to everyone. My name is Dr. Harsh, and I am kind enough to present my thesis here. Thank you, Americon, for the opportunity. So our thesis was on detection of ANA by IIF patterns with the help of artificial intelligence. Firstly, I would like to acknowledge everyone who has supported us to finish this in time, especially my guide, Dr. Karthik Sivasamy sir. We had actually joined hands with Ashoka Institute of Sonipat, Haryana, where we had processed all these images and we had given them the images to train various convolutional neural networks. So we know that we have been following ICAP for a while to classify ANA patterns. So why we did this study was that we wanted to improve the interpretation of ANA and we wanted to see how AI does. Uh, and we wanted to correlate how our accuracy was compared to the AI. Because what we have seen is that many lab reports, what we see is they will provide ANA reports like AC2, 3, 4. Everything is speckled positive, cytoplasmic positive, and at times what the major confusion happens is AC29, which is a topoisomerase pattern, is often misclassified as being speckled or homogeneous because the result will vary because if ANA is homogeneous, it means that they might have dsDNA, histones or nucleosomes. But if AC29 is positive, definitely the patient has SCL7. So we cannot avoid such mistakes. So we wanted to address that there is high inter-observer variability who is seeing and reporting the ANA matters the most. So this was a first Indian study to utilize artificial intelligence, which used specific CNN models. So we used YOLO V8 model. YOLO is you only look once for detection of ANAs. So without wasting, I would start my presentation. So we had done a 18-month prospective observational study. We had collected around 803 high quality ANA samples, which included AC1 to AC5, and also had some negative samples of around 2000. We had processed these images into RBG, that is red, green, blue, because when the AI looks at images, we have to remove the red and the blue part of the image so that it can focus only on the green channel intensity. Because if there is random noise, AI will not be able to process it. Sorry, 1 minute. So we removed the red and blue parts of the digital images because they were just noise. So this is like adjusting the brightness and contrast on every single image so that everything has a starting point which will make it easy for the AI for detection. So here we can see we had received around 3,712 ANA patterns. Out of those, 2,909 were excluded because these patterns were mixed patterns. Our AI wasn't ready. It was a very fresh CNN network. 322 patterns were other than AC1 to AC5, and three observers were reporting the ANS. So, if they had any disagreement, those images were removed. So, around 44 images were removed because of non agreement, and negative patterns were around 2,226. So total we had used 803 samples to train our CNN models. So 87% of the samples were positive and 99 were negative samples to ensure a balanced non-biased data set. Otherwise, if we had more of negative samples, the AI would have seen more of negative and would have reported more negative. So standard procedure was followed using HEP2 cells, and we had acquired the images using Luminera Infinity 2 camera, and three independent observers had classified patterns based on ICAP standards. So coming to deep network. So whenever we see a ANA in the Microsoft, what we do is we divide it using a classification that whether it is negative or positive. So we needed to simplify the work for AI. So what we did is we picked six uh, ANA samples which were easiest to pick up on microscope, that is AC1, 2, 3, 4, 5 and negative. So first is the sample negative or positive. Second is metaphase staining, because with the help of metaphase we are able to differentiate whether it is AC1, 2, 3, because we know that metaphase staining is seen in these patterns and not seen in AC4 and 5. After this, we differentiated these patterns from each other with the help of using seeing specific coarse granulation of ions granulations within the nucleus. So it's like divide and conquer method, which is the reason why our model performed very well. So here we can see it is a multi-stage classification where we did whether the ANA is positive or negative. Second is whether the metaphase is being stained or not stained. Then the cell pattern classifier, whether it was homogeneously stained, speckled or centromere. And we know that we have to divide between speckled because AC4 is fine speckled and AC5 is fine speckled. So this is how AI was trained, that the metaphase is stained, the cells are homogeneously stained in AC1, and here we can see AC4 and AC5, the metaphase was not stained. So here, this is the RBG technique. So the image is being taken, is captured via the microscope. We have removed the red and the blue part, and we have given the green color so that we have normalized the intensity of all the images. So the images are not too bright, not too light. So we had tested these 8 models which are available online. So we had tested a baseline model also and a pre-trained model also. What do you mean by pre-trained? Pre-trained means transfer learning. Think of this as a pre-education. We used models that already knew how to see shapes and edges from millions of journal images and then specifically trained them on medical patterns. So YOLO V8, that is you only look once. This is a state-of-the-art object detection model. This was used for finding cars or people in videos, and later on it adapted and it showed much response to find subtle features in complex backgrounds. So we divided our data into 4 groups. We so here we classified them into single 6 class models, that is negative, positive, metaphase, non-metaphase, then cell classification and coarse or fine speckled. So YOLO had shown very high accuracy of around 81.16%, with an overall average of about 92%, and an achieved near perfect accuracy of 98% in distinguishing positive or negative samples. So 11 was positive or negative. If we take a deep dive and see the accuracy across various other patterns, so it had almost shown around 90 or more than 90% accuracy at various levels in distinguishing patterns between whether they are negative, positive, whether it is between AC1, 2 or 3, or whether it is between AC4 or AC versus AC5. So coming on to data splitting. So what we did is that we had 803 samples. We divided them into 5 different folds because 4 sets were chosen to train and 1 to test. It was divided in the ratio of 90 is to 10. So we do this because it reduces overfitting, because if we simplify the randomization, it will do very well on the testing data set, but it will fail. Sorry, it will do very well on the training data set because it has already seen images, but it will perform very badly on the samples which this ANA AI, that is the CNN, has not seen. So it is very important that you divide or do a 5-fold cross validation so that it has seen all images and it has been tested on all images. So if we see this confusion matrix, so this is the negative sample, this is a non-negative, that means positive. So very few false positives can be seen. Around 126 patterns were seen to be positive, rest negative. Here also we can see it was able to identify all the negative samples properly. if we see the area under curve for all the levels, that is metaphase versus non-metaphase, negative versus non-negative, the area under the curve is very close to 1. It is around zero point 0.9. So our YOLO model had done very well in distinguishing, but the only problem was that distinguishing between AC4 and AC5. That was a bit trouble. We also face problem when we are trying to distinguish between AC4 and AC5. So we'll have to provide more data to the AI so that it doesn't make such mistakes when it is distinguishing between AC4 and AC5. So if we now see the full six classification, we can see this diagonal arrangement. So majority of the samples were reported correctly, but if we see between AC5 and AC4, we had some false positives. That is, three were detected as AC2, four were detected as AC5, and here in AC5, eight were detected as AC8, but they were AC5. Similarly, in the test data set, we can see because the number has dropped because the data set was 10%, right? So here also we can see AC5 were actually 16, but 6 were falsely detected, one being AC2 and 5 being AC4. Now that was the problem which we faced. But if we see AC3, everything was correctly labeled as AC3, and AC1 here 32 and AC1 here as 18. Only two were falsely labeled as AC2. At times it is difficult to distinguish between AC1 and AC2 because the metaphase is stained in both these patterns. So the overall accuracy was around 80%. For any AI model to be good, the accuracy should be above 70%. So our model had an overall accuracy of 79, and this was the base model. It means that it was not pre-trained on any images of any medical images. So if we see the pre-trained one, see here we can see the accuracy of YOLO has reached around 94% if it was a pre-trained model. So we compared both pre-trained and the baseline model, which was not trained with images. So the precision here was 81, but here the precision was 94%. So what lies next in this? We know that there are subtle visual differences between AC4 and AC5, and it remains difficult to distinguish them completely. The scope of further AI research is that we had only chosen five common patterns. We had not included nuclear patterns or mixed patterns because we wanted to see how our AI model does with the simple ANA patterns. So the future opportunity lies that we can include larger data set for rare patterns. We can identify mixed patterns, and we can combine this AIF images with clinical data or ANA blot to assess how, if some ANA pattern, suppose AC29 comes, if the AI is able to uh, say that this might be SCL70, or if we have speckled 4 and 5. We also know that apart from ROLA, SNRNP, and Smith, speckled can be seen in Ku. So whether there is some difference in the patterns with which we can identify that Ku antibody will be positive, this will only be confirmed after multiple research and multiple trials and errors. So this is what we think in near future AI would be able to help us identify and give us rapid results, because uh, training of looking at the ANA patterns is also a tedious task, and reporting also takes a lot of time. So thank you. I hope I was able to make it a bit more clear. At times understanding this AI and the softwares and the techniques what they have used might can be difficult at times. So I hope it was not too overwhelming. Thank you.
Yeah, so very nice presentation, Dr. Harsh. Anyone has any questions, we can take it in 2 minutes, then we'll move on to the case. Uh, Anyone has any questions? Okay, yes. So should we move on to the case? So Nidhi, kindly load your presentation. So today we have a case presentation by Dr. Nidhi Bhutada, who is a student fellow at LTMC Sion, who will be presenting a case of a young female with digital gangrene, dyspnea on exertion, and skin thickening. We have moderators, Dr. Smruti Ramteke ma'am. Ma'am is a consultant rheumatologist at Ilyas Hospital, Nagpur. She is a founder president of VRA, and she has done many research publications and trial. She is active member of SIG Sjogren and has research on fibromyalgia also. So welcome, ma'am. Also, we have Dr. Gayatri Egbote, who is a consultant rheumatologist at Dinanath Mangeshkar Hospital. She is she is working at Egbote Hospital also, and she has her research in ANCA vasculitis. So we have these two great moderators, and we have a guest lecture by Dr. Adarsh sir. Adarsh MB sir is assistant professor in rheumatology in GMC Kozhikode. He is a alumnus of PGI Chandigarh. He has done DM from PGI Chandigarh. He has revered for his research in systemic sclerosis like SSC, ILD, GI, SSC, and he has contributed immensely to the ANCA vasculitis guidelines by IRA. Uh, so, welcome, Adarsh sir, and we will have his guest lecture after the case on GI involvement in scleroderma. So, I request Nidhi to start the case presentation. Uh,
Yes, sir.
yes, over to you.
Yes. Mm.
We'll have 45 minutes case presentation.
So 1 second, my slides. Uh, 30-year-old female married resident of Mumra, Thane district, housemaker, presented with chief complaint of blackish discoloration of toes of bilateral lower limb since 1 year, breathlessness on exertion since 1 year, dry cough since 2 to 3 months, fever on and off since 2 to 3 months. History of presenting illness. Initial onset of symptoms was from 2016. She first noticed episodic color changes of finger on exposure to cold, initially turning white, followed by bluish discoloration, and subsequently returning to normal on rewarming. These episodes were associated with fingertip ulcers and pitting lesions. Over the subsequent months, she developed progressive tightening of skin involving the digits, forearms, legs, and face associated with difficulty in mouth opening. She also complained difficulty in swallowing, predominantly for solid food more than liquid, for which she took treatment from local doctor and the symptoms improved. In 2018, the patient experienced recurrence and worsening of the above symptoms. For, yes, for which she consulted a rheumatologist, and she had received 6 monthly injections and 2 quarterly injections and then was shifted to oral medication. She had partial symptomatic improvement. In 2020, the patient lost to follow-up and had stopped all medications on her own. Now, since 2024, since the past 1 year, the patient developed blackish discoloration of the toes of both lower limbs, along with ulcerative lesions over the fingertips of both hands. The symptoms were insidious in onset, gradually progressive, associated with severe pain, which worsened at night and on exposure to cold. She also complains of burning sensations, joint deformities, and discharge from the lower limb ulcers not associated with any tingling or numbness. She also developed breathlessness on exertion, insidious in onset, initially MMRC grade 1, which progressed to MMRC grade 2 over the last 3 months. I was associated with dry cough. There was no history of any chest pain, wheeze, hemoptysis, orthopnea, or paroxysmal nocturnal dyspnea. Additionally, she reported low-grade fever, intermittent in nature, for the past 2 to 3 months and was not associated with chills or rigor. Negative history. There was no history of any vomiting, diarrhea, or abdominal pain. No history of frothy urine or oliguria. There is no history of current dysphagia. No history of any myalgia, proximal muscle weakness, or joint pain. No history of any photosensitive rash or Zika symptoms, parotid swelling. No history of any headache, seizure, or tingling numbness. Past history was described as previously. Personal history, she has a normal bowel and bladder with sleep disturbed due to pain, with regular menstrual cycle, and she had one abortion at 8 weeks. Her treatment history in 2016, when she presented with Raynaud's phenomena, skin tightening, and esophageal mobility, she got symptomatic treatment with antacids and was further when 2018 she had worsening of symptoms. She had received 6 cycles of injection cyclophosphamide followed by 2 quarterly cycle and was shifted on mycophenolate. After which, in 2020, she lost to follow-up and has stopped all treatment. Now she presented with breathlessness and gangrene. So, summary from history. A 30-year-old female, symptomatic since 2016, with a history of Raynaud's phenomena, progressive skin tightening, and esophageal dysmobility, previously treated with cyclophosphamide and MMF, has defaulted treatment, now present with critical digital ischemia with black discoloration slash ulcer, progressive dyspnea MMRC2 and dry cough, low-grade fever, probably diagnosis is systemic sclerosis diffuse type with severe peripheral vascular involvement and probably pulmonary involvement, ILD or pulmonary hypertension. Should I continue, ma'am?
Uh, what was the negative history which you have asked?
So history of either organ involvement like GI involvement or renal involvement and associated other like any connective tissue disease symptoms.
Like
Ma'am,
what are you like suspecting apart from scleroderma? Are you suspecting anything else?
no, ma'am, just for like overlap symptoms for
Okay.
any myositis or any overlap Zika symptoms for that, ma'am.
So how do you define overlap syndrome?
Ma'am, sorry, clinical features of 2 or more CTDs, which are seen, but full-blown CTDs are not full-blown single disease is not manifested.
So, Nidhi, I want to ask you one question. I'm Dr. Gayatri. Can you
Yes,
just
ma'am.
go back to your treatment slide?
Yes, ma'am.
So you said between 2018 to 19, she received immunosuppression, right?
Yes, ma'am.
So could you tell me as a doctor why would she receive immunosuppression for just for Raynaud's skin tightening and esophageal dysmobility? Do you agree with the treatment plan?
No, ma'am, because she at that time she had did not have any internal organ involvement except GI involvement, and
Yes.
she had like her GI endoscopy at that time showed a peptic stricture. For she had undergone a procedure, upper GI scopy. Other than that, she never had dyspnea or any renal involvement.
No, so that's okay. So I'm just asking you, can we just go back to basic thing about scleroderma? Okay. For the people who are listening here, could you just tell us the triad of systemic sclerosis?
Ma'am, Raynaud's phenomena, skin tightening, and digit.
No, so we have Virchow's triad, right? You have heard about Virchow's
Yes,
triad.
yes, ma'am.
Like that, we have a triad of scleroderma or systemic sclerosis. Okay, so which is just for everything. Like even in the we have a scleroderma predominant MCTD, scleroderma predominant overlap CTD. It's not just diffuse cutaneous and limited cutaneous, right? So you
Yes.
have vasculopathy, okay, fibrosis, and autoimmunity. So
Yes,
autoimmunity is the initially in 3 to 5 years, autoimmunity is one of the most important factors, right? So
yes, ma'am.
the research says that if you are treating scleroderma within 3 to 5 years of onset, okay, then you can actually reverse sclerodactyly or whatever. Then later it's more about vasculopathy and then fibrosis eventually. So even internal organ involvement like interstitial lung disease or GI manifestations later on. I'm talking about something which is 5 years later. That could be also because of the fibrosis. Okay. So you know the cytokines involved, right? So later TGF beta is one of the most important cytokines later on. Okay. So now when you are treating somebody from 18 to 19, that too with cyclophosphamide and mycophenolate, they're quite strong immunosuppression, right?
Yes, ma'am.
So obviously you had not seen the patient at that time. So logically, could you just tell us why such a strong immunosuppression was given to that patient?
So, ma'am, because of severe like skin involvement, then Raynaud's too. Maybe she had previously also she had digital ulcer and to treat for that maybe she had received such immunosuppressant.
Okay, so as much as I know, immunosuppression, strong immunosuppression is given only whenever the disease is the autoimmunity or the we have something which is sinister. So in cases of say interstitial lung disease which is rapidly progressive, or somebody who's got myositis not tolerating to other conventional DMARDs, somebody who is not tolerating your conventional DMARDs. Okay, so just for Raynaud's, we usually don't give cyclophosphamide or mycophenolate. Skin thickening, yes, you can, but you usually try and give something lighter, like azathioprine or methotrexate, etc. Okay. So
Yes,
I'm just curious why initially why did you give cyclophosphamide? Smriti ma'am, do you have any take on this?
Yeah, I don't think that initial part and looking at the age, uh, cyclophosphamide was indicated so early. Second thing is mycophenolate and giving her PGs would have like solved the problems, but it doesn't look justified.
Okay, so we have here we have few SRs, rheumatology SRs we have joined here.
Okay.
We have I don't know. Abhijit is done his fellowship. We have Arvind.
I
Okay.
just wanted to ask her about how do you define overlap and how do you define
Hmm.
undifferentiated connective tissue disease?
Nidhi.
yes, ma'am.
So, ma'am is
Uh,
asking difference between OCTD and UCTD. You understood the question, right?
ma'am, you in UCTD patient may have yes, ma'am. Uh,
Yeah.
Ma'am, initially in like UCTD, like presentation of symptoms may not be fully presented of all the clinical features. And in overlap syndrome, there will be overlapping features of two or more connective tissue diseases.
So the criteria have been completed in overlap, while the criteria are
Okay,
not
correct.
complete in undifferentiated.
Mhm.
So, can you tell me you have UCTD literally means undifferentiated CTD. So, that can evolve later, okay,
Yeah.
into any full blown CTD. So, can you tell us which is the commonest pattern of UCTD? I mean, which is the commonest disease it can evolve into?
Ma'am, mostly SLE, most commonly patient with UCTD evolves into SLE later.
Are you sure?
Uh, Not sure, ma'am, but
Okay. And then followed by?
followed by mixed connective tissue disease or systemic sclerosis.
Okay. So basically, you see, if, when you are like you have these three things, you have these three diseases: UCTD, overlap CTD, and MCTD. Okay, so UCTD we cannot say that UCTD will evolve into MCTD. MCTD itself is a criteria. So because
Yes,
entry criteria of MCTD is UN1 RNP positivity. Okay, understood. So
yes,
yeah,
ma'am.
so SLE and scleroderma, systemic sclerosis are two of the commonest diseases UCTD can evolve into, followed by
Mhm.
Jogrens and then RA. Okay, right. Okay, then fine. So just tell me, patient had Raynaud's. So obviously you have not seen the patients, this patient. So okay, we can go to your next slide. We can go to examination. Yeah.
General examination. On general examination, vitals were pulse of 82 per minute, BP of 120 by 80 mmHg, and respiratory rate of 18 per minute. Her BMI was 18.2, which was she was underweight. She had no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or edema.
Okay,
On
sorry, just I'm interrupting you here. So
yes, ma'am.
this general examination you yourself have done, right?
Yes, ma'am.
So this was done in which year? 25.
Yes, ma'am. Now.
Okay, so after 9 years of illness, right?
Yes, ma'am.
So this is important.
Mhm.
And I'm sorry, I think I forgot the history of weight loss. How much weight she's lost so far?
Ma'am, like she couldn't specify how much kg she had lost, but like her relatives were telling ki she had like her clothes were loosed and all that, and she has lots of
That's okay.
appetite.
So how old
So
is
can
she?
you just sorry.
No, ma'am,
Yes,
please go ahead.
No, I was just trying to ask her what can you enumerate what are the GI manifestations of scleroderma?
yes, ma'am. There can be dysphagia, uh, like dysphagia. Then uh, sorry, ma'am, 1 second. Um, there can be dysphagia, difficulty in eating due to restricted mouth opening, and there can be acid reflux, GERD symptoms. There can be intestinal involvement in view of bacterial overgrowth syndrome, bacterial overgrowth. There can be constipation or recurrent diarrhea, and there can be malabsorption.
Okay.
So, Nidhi, whenever
Esophageal
somebody asks
dysmotility?
you,
Yes, ma'am.
Yeah, maybe you can distribute it into different parts of the GI and then answer the question. And anything about the esophageal dysmotility which the patient has?
With dysmobility, she might have, ma'am, recurrent dysphagia or acid reflux, and later on, like lose esophageal sphincter for them.
And how would you want to investigate this patient? Sorry, I'm jumping to the investigation, but to
Yes,
complete
ma'am.
to complete the thing.
Ma'am, we can go for
Sorry.
upper GI scopy.
Okay, and to what is the investigation to see for the esophageal pressures?
Ma'am, manometry, esophageal manometry, and or barium swallow we can do.
Correct. Yes, Gayatri,
so
please.
yes, ma'am, sorry. So, Nidhi, you've done medicine, right? MD, DNB, whatever.
Yes, ma'am.
So, I assume you've done MBBS, right?
Yes, ma'am.
So now if somebody asks you GI manifestation of scleroderma, you can't just go here and there, okay? You have to start talking from oral cavity, okay?
Yes,
Because
ma'am.
you will be a consultant rheumatology after few months or probably after 1 year, okay? So start with oral cavity. So just you have to give answer properly. So oral cavity, microstomia, or sometimes they can have secondary Sjogren's. They can have
Yeah.
a lot of dryness of mouth. So xerostomia. So GERD dysphagia, esophageal stricture that comes under esophagus. Okay.
Yes, ma'am.
Then what is
Yes.
the most important OGD appearance of stomach in scleroderma?
Ma'am, gave,
Yes,
gave.
gave, right. So you could tell like that, right? So you
Yes, ma'am.
can't say first GERD, then say again acid peptic manifestation, then rectal prolapse. Okay. So don't answer like that. Okay.
Yes, ma'am.
Okay. This is for everybody, not just for you.
Yes.
Okay. Then go ahead.
Head to toe examination. Her hair was normal. Face has a taut, tight, shiny skin with hyperpigmentation around the eyes, with decreased wrinkling of forehead. Ingram sign was positive. Parrot peak or pinch-nosed appearance was there. Oral cavity, mouth opening was two fingers with bursting appearance. On the neck, she had Barnett neck sign was positive, and she had salt and pepper appearance. Hand skin tightening extending above the elbows were present. Calcinosis cutis over the both elbow joints and fingers was there. Flick flexion deformities at the PIP and MCP joint of both hands was present. Lesions over the dorsal aspect of DIP joint with resorption of DIP joints was there. Her finger to palm distance was 1.5 centimeter and there was no tendon friction rub. She had gangrene involving the great toe and the second toe of right foot, extending up to the MTP joint with blackish discolorization and purulent discharge, with well-defined line of demarcation present. Affected toe was cold, tender, and all peripheral pulses were present. She had lost her third and fourth toe of both feet. Her MRSS score was 24. Sir, these are her pictures. Um,
So, according to you, phenotypically, at
Yes,
this stage, phenotypically, what do you
yes.
think she has? It is diffuse cutaneous or limited cutaneous? Just
Ma'am,
from the
diffuse,
history and from the history and clinical examination.
ma'am, diffuse cutaneous involvement.
Why do
She
you say so?
she had skin thickening over the chest, over the arms, like above the
Hmm.
elbow, was also involved.
Okay, good.
Mhm.
So above elbow, above knee, and then diffuse involvement,
Yes,
right?
ma'am.
Yeah.
Systemic examination, RS examination, air entry was bilaterally equal. Her chest expansion was 2 centimeter. She was not able to perform 6-minute walk test. Bilateral fine and inspiratory basal crepes were present. The other system examination was normal.
So could you please go back to calcinosis cutis?
Yes, ma'am.
Yeah. So just this you didn't tell us properly. These are beautiful pictures for the PGs. I mean for the SRC in rheumatology over here.
Mhm.
Could you please explain how do you examine and could you please explain these findings?
Ma'am, she had calcinosis cutis on bilateral elbow and on the dorsal aspects of her MTP joint and her DIP joint, ma'am.
So right. So if this case is just presented to you as a short case, or if like just as an OSCE, and you don't know the diagnosis, and you are asked to just examine this particular part. Okay. So
Yes,
what are
ma'am.
your DDs for this particular part of examination?
Um,
You
one
have
second.
DDs for everything, right?
Yes, ma'am. Other than calcinosis cutis, I'm not sure actually.
So TOFA is one of the differentials. Is it not?
Yes, ma'am, but like associated joint involvement, joint swelling, and
Yes.
no, that nothing was present. She did, like no joint involvement is
Yeah.
there, only knee.
So that is another part. I'm just
And
telling you, you should have
yes,
some
ma'am.
DDs. Okay.
Yes,
Right.
yes, ma'am.
Okay. Right. Chalo. Aage.
Mm.
And there is no okay, there is no discharge, right?
Yes, ma'am, there is discharge. Like purulent discharge was present from these lesions actually. The toes which
Okay.
have fallen off from there, ma'am.
And had she been an elderly female or elderly man, then you have to obviously think about dystrophic or metastatic calcification. Okay, if you don't have other features.
Yes, ma'am.
Mm. ठीक
Final
है.
diagnosis 30-year-old female, symptomatic since 2016, history of Raynaud's, progressive skin tightening, esophageal dysmobility, previously received immunosuppressant but defaulted treatment, now presented with critical digital ischemia manifesting as dry gangrene of toes with superadded secondary infection, progressive dyspnea on exertion with dry cough suggestive of interstitial lung disease, and low-grade intermittent fever, diffuse cutaneous systemic sclerosis with severe peripheral vasculopathy leading to critical digital ischemia and gangrene and interstitial lung disease.
Okay.
So, are you attributing the fever to the disease
No, ma'am, to the
or it is something
infection,
else?
to the superadded infection, her gangrene has been infected, ma'am, which also had discharge. That
Okay.
because,
So, has it
uh,
been treated?
yes, ma'am. I had further investigation, which the culture was sent for that swab culture, and it came out positive to be growth of MRSA, ma'am.
Okay.
So just Nidhi, just tell me one thing. Right now, she is not on any immunosuppression, right?
Ma'am, we have given her, like when she presented, she was not taking anything. On further, we had now given her immunosuppressants.
What are you giving her?
Ma'am, we had like after this antibiotics and alprostadil we had given, and after which she has now rituximab 2 doses, ma'am.
When was the last rituximab?
15 days back, ma'am.
Okay, but what was the indication of for rituximab in her?
Ma'am, for like ILD and significant skin involvement with ILD also, ma'am.
But it's been 9 years
So,
since disease onset. Do you think rituximab will help?
Ma'am, actually, she was not taking treatment for anything, and her disease was progressive. So, actually, for that reason, because previously when she was treated, she didn't have any ILD or any other organ involvement, but she
Acha,
now had.
so okay, ILD is new onset, you mean?
Yes, ma'am.
Okay, right.
so was that given in the presence of infection?
No, ma'am. First, we treated the infection, and afterwards, she was given rituximab.
Okay.
Have you ever done 2D echo in her?
Yes, ma'am. I have investigations. Her
Sorry, yeah.
initial routine investigations were normal. The HB of 9.3, WBC 7,000, platelet 5 lakh, ESRC of 15, and CRP of 3.5. LFT were normal. Creat was zero point 0.4. TSH was normal. ANA was 1:160 nuclear oil pattern with SCL 70 positive. Urine RM showed trace proteinuria, but her 24-hour was 135 milligram. APLA profile was negative. Pus culture show growth of MRSA. So her bilateral lower rim Doppler was done, which was normal. HRCT was suggestive of features of interstitial lung disease. 2D echo was normal with no pH, and PFT showed small airway obstruction with moderate bronchodilator reversibility. FEVC was 55%, FEV1 was 57.9%, and the ratio was 104. So treatment, we started her on first culture sensitivity antibiotics. She was given L-prostidil for 5 days. Later was started on bosentan, and she had now received 2 doses of injection rituximab.
So she never had any arthritis or myositis, right?
No, ma'am, never.
And how much steroid you have given her? Or just
No, ma'am.
rituximab?
Ma'am, with rituximab, we just have given her single shot of 125 mg, actually MPS.
Okay, so there is no oral steroid.
No, ma'am, no.
Okay.
Nidhi, just one question for you.
Yes,
Do you
ma'am.
think this patient might be having any associated antiphospholipid antibodies?
Ma'am, actually, she had one history of abortion also previously, after which she never
Yeah.
conceived her. And so we had just done her APS profile for that.
So was it positive?
No, ma'am, negative.
Okay, you have mentioned it?
Yes, ma'am.
Yeah. Okay.
So what do you think? What is the cause of the miscarriage in this patient if APLA is negative?
Uh, ma'am, vascular
Yes, yeah, you're right.
disease associated vasculopathy,
Yeah.
which can also cause.
Anybody else also can answer. Digvijay, we can ask questions to other PGs also,
Yeah.
no?
Yeah, you may ask, but how many of them are there? I don't know.
Or they are awake.
Yeah.
Okay, so basically, Nidhi, yeah, this is the most important thing. They will ask you when you become a consultant, the scleroderma ladies will ask you, can we conceive? Even if their APLA profile is negative, obviously it's a high risk pregnancy. Why? You, as you just said, it is vasculopathy. So you have because of the vasculopathy in placental arteries itself, you can have IUGR, etc. Right?
Yes, ma'am.
Okay, yeah. And you mentioned about alprostadil. So what is alprostadil?
Ma'am, it is a phosphodiester inhibitor which
Sorry, alprostadil is what?
critical.
Is it what? Is it phosphodiesterase inhibitor?
I think we can ask the other ones as well.
In
Yeah.
associated.
So it is PGE1, right?
Hmm.
So you have to read about vasodilators, okay? This is very important. Okay, fine. Ma'am, other PGs, I don't know whether they're there. They're there.
Yes.
There are multiple people who have joined. Probably,
Okay.
yes, ma'am. Okay. So Nidhi and other PGs, please read about treatment of vasculopathy in scleroderma. How do you treat Raynaud's, pregangrene, etc. And you need to know about mechanism of action of
The
all
patient.
these drugs. Yeah.
Even I would request others, sir, also to ask some questions.
Yeah.
If he's able to ask.
Thanks, Digvijay.
Yeah.
So I'll just revise the final diagnosis. The final diagnosis in scleroderma should have some more the severity part also. Like if it will be better if we can score the skin and write the Rodnan score there. And whenever we are saying interstitial lung disease, it's always better patient in MMRC 3 or 4, whatever the
He
breathlessness she has, and if
he
they
has,
she's
yeah.
in type 1 respiratory failure, you should say she's in respiratory failure or she's not in respiratory failure. That aspect also need to be given in the final diagnosis. And second one I want to add is regarding the gangrene. We attribute all the gangrene to the severe Raynaud's she has, but we always have to rule out a larger vessel involvement. Like they are also prone for significant atherosclerotic disease. Sometimes an
Yeah.
overlap vasculitis is also known to happen. So whenever the patient has a little more extensive gangrene, and it's always better to imagine the larger vessels. Like we always go for a Doppler of the lower limb or upper limb, just to ensure that we are not missing the obstruction above. And if we give more vasodilators for predominantly for the smaller vessels and all, so if there is a fixed obstruction above, it is not going to work. So sometimes what you may need is an intervention up above the in the larger vessel, so that the lower vessels will also get enough blood supply. So it's always better to just rule out extensive medium vessel involvement. So especially atherosclerotic or overlap, especially when you have associated vasculitic manifestations like an renal associated renal dysfunction or mononeurotics or something like that, then it is always better to rule out secondary vasculitis.
Yes.
So this is something which we may miss, because that treatment also adding the other drugs, just stopping at vasodilators is also, we can add. Actually, the pain relief itself is very important. Giving adequate pain relief is important, and combination of therapies, because we have prostaglandin infusion is given only for the initial 4 or 5 days, and then we give it every six weekly or and 2 monthly. But if you can combine for very severe Raynaud's, it is okay for to combine PD4 inhibitor plus endothelin antagonist. So that is also needs something which you can consider in these patients. Even adding SSRIs like can also be given for them. And if there is significant large vessel involvement, adding and statins can also sometimes be beneficial. We don't want to add the number of drugs, but only if needed you can add, especially if there is extensive larger vessel involvements. And giving antiplatelets, it's actually a double-edged weapon. So sometimes it can, as Madam told, you have GAVE and other vascular ectasia. So giving aspirin may be counterproductive. They can worsen the GI blood loss and worsen the anemias and all. But in this patient with the significant, I hope I think she has an, it's not just Raynaud's, she has some more extensive disease. So sometimes aspirin or uh, rheogenic agents as we give for peripheral vascular disease may be of some benefit, but this needs to be weighed upfront. Like whether it is going to benefit or not, we need to weigh once more. So that's also an in addition to the immunosuppression and vasodilators. So overall, Nidhi presented well. Just have to change to little bit of here and there. And examination part, whichever for direct exam point for DNB and others, usually they do ask a lot of question on your system examination. Or once you say only biphasic basic laptop, for the presentation part it's okay, because we have only 15-20 minutes to present. But they may ask you about the Krebs. They can ask you about what are the signs of right ventricular dysfunction, corpulmonale, other features, and the types of pulmonary hypertension pH versus type 3 pH. So such questions are usually the ones which most of the senior examiners ask in DNB exams. And then of course they will go into the guidelines, and you should be thorough with the recent guidelines what is available, the modifications and the recent ULAR 2023. And so guidelines is a must for that. And some of the examination findings they may ask. Overall, nice one, Nidhi.
Thank you,
Sir,
sir.
I have one question to you. Just what is the significance of scleroderma profile, which is there now? In established diagnosis of scleroderma, when do we use it, and what is the exact indication? Where should we ask patients to do that?
So the thing is, current ANA immunoblot itself
Hmm.
gives us the major three
Yeah,
antibodies, which will give us CL70 and topoisomerase and the RNAP3. Those three are there, but and overlap in PM myositis scleroderma PM SCL antibodies also there in the 16
yeah,
antigen immunoblot. But when going beyond that is one is having a seronegativity is very less likely, but if you think it is clinically it is scleroderma and you are not able to get the proper antibody, then you can go for that. The otherwise, uh, when you have a predominant myositis, the fibromyositis variant, when you have
okay,
extensive myositis plus significant, clinically significant myositis also, then that can also add on to. Otherwise, treatment ways, we don't have much benefit of going beyond the routine immunoblot. It's an actually not, it hasn't come out of the lab yet, but started using sort of thing.
yeah,
So I usually go for the routine ANA immunoblot, re- and with the clinical examination and the features, we can diagnose scleroderma definitely.
yeah, definitely.
And if there is one antibody, then I will usually go with the based on the domain of involvement and severity, the treatment part is decided. So
Okay.
that is something.
Yeah. So thank you, sir. Can we move to the guest lecture by Dr. Adarsh, sir? Sir, you can please share your PowerPoint.
Uh, Let me just say that
Oh,
Nidhi,
sorry.
you had an excellent presentation, and you presented it very well. But you should go into the details of the treatment as well. Treatment, just read it well. Hmm?
Yes, ma'am.
And Gayatri has moderated very well. Thank you, Digvijay, for the opportunity.
Thank you, ma'am. Thank you.
Yeah.
Uh, there will be a guest lecture after this. Just be there. Sir, can you share your slides?
Uh, is it visible now?
Yeah. Yes.
Okay. Thank you, Digvijay, once more for inviting me for this guest lecture and the case presentation. And gastrointestinal involvement, I'll straight away start. Gastrointestinal involvement is something which usually the problem is we underestimate sometimes because we are more concerned about those domain of involvement which are more involved in mortality and which are more obviously visible, like the skin is obviously visible and patients are more concerned about it, and interstitial lung disease and pulmonary artery hypertensions are life threatening more often. So sometimes we underplay the gastrointestinal involvement in systemic sclerosis, but it is not the fact. Actually, nearly 90%, most often the patients who have of 2 or 3 years of disease onset, most of them will have some sort of GI symptom prevalence, and nearly around 5 to 6%, the mortality is directly attributable to scleroderma. Especially the GI vascular involvement is the one which can lead on to the mortality in them. The gastric valve, antral valvular ectasias, and other vascular changes, and also the infections that they are prone for, and the severe malnutrition they are going through. These are all can attribute directly to the mortality of the patient and also can add on to the morbidity. And it is the most common internal complication. It's more than the interstitial lung disease and pulmonary artery hypertension. So it is actually a significant thing. And it's not that we will have to think about the gastrointestinal manifestation when the patient complains of success, like they have GERD or they have abdominal distension or they have diarrhea or constipation or like that. But sometimes it may not be an evident gastrointestinal symptoms, but you can also have GI involvement from unexplained anemia. If the patient has no active GI blood loss and the patient has anemia, especially if the patient has iron deficiency anemias or B12 deficiency or folate deficiency, multinutrition deficiency anemias. The other condition where the condition that we suspect when we have an unexplained anemia is when we have rapid progressive renal dysfunctions and when we are thinking of scleroderma renal crisis. Sometimes it can also present with just unexplained anemia. So these are the two conditions you have to think of when you have unexplained anemia in patients with scleroderma. And other presentations of multinutrient deficiency or the patient has unexplained weight loss. Most often they have a very gradually progressive weight loss. So these are the conditions when you have to think of significant GI, clinically relevant GI involvement in such patients. The spectrum, there is a wide spectrum of GI manifestations. It's heterogeneous. It can start from the opening anteriorly until the opening posteriorly. So you can have oral cavity manifestations, esophagus, stomach, small intestine, colon, rectum. We'll come to it in the next few slides. So this very diverse. It is not that one compartment alone is involved. There is an actually a sort of graded or overlapping. The symptoms also overlap and the manifestations also overlap. Just before going to the clinical manifestations, the pathophysiological mechanism is important. Why? Because as in the previous presentation, Gayatri ma'am was talking about the vasculopathy panel. So we know the pathology of systemic sclerosis is predominantly the initial endothelial dysfunction and the vascular abnormality, which is leading on to significant tissue hypoxia. Then hypoxia induced the activation of fibroblast changing into myofibroblast, and then there is uh, extensive fibrosis of the tissues. This is the common mechanisms which underlie most of them. But in GI manifestations, there is a little different. It is not clear until now, but there is an increased involvement of the neuronal tissues involved. We know that the entire GI system is being managed by autonomic nervous system, the enteric nervous system. So there is an early involvement of enteric nervous system in these patients and leading on to smooth muscle atrophy. The smooth muscles are being supplied trophically by these enteric nervous system. And there is a component of vasculopathy and there is a component of terminal fibrosis also. But this fibrosis is not as evident in GI system as we have in interstitial lung disease or the skin findings of the patient. So in addition to these vasculopathy and the tissue ischemia fibrosis, the one that stands out in GI manifestation is the neuronal dysfunction, especially the enteric nervous system autonomic, whether it is vagal nervous system or the sympathetic neural system. It's predominantly a neurological system involvement, smooth muscle atrophy, and later on fibrosis. So the what we expect in fibrosis is more of an obstruction and strictures, but what happens it more faces a dysmotility predominant disease. So it is the GI manifestations can itself be classified into two. One is due to the dysmotility, the other is due to the dysmotility and the things arising out of the dysmotility, like the bacterial growth or the other symptoms. And second one is vascular malformations and the manifestations involving the GI system. So it's rather a sequential process. There is a neural dysfunction followed by smooth muscle atrophy and ultimately fibrosis. The thing is, the neural system, what we think of mostly as that it causes contractions, it causes mainly we related to the motility part, but the nervous system is actively involved in the immunity of our system, especially GI tract system. Immune processes and the immunity, first line immunities are all controlled by our the enteric nervous system. So on the left panel, you can see a normal healthy small intestine, and here you can see the small intestine in scleroderma. So there is an atrophy of vessel atrophies, neurological atrophies, and there is increased immune cell activations like more lymphocytes into it. There is a dual atrophy of the mucosa which happens, and then there is extensive infiltration by immune cells, and then immune infiltrations, and there is leading on to the smooth muscle loss, smooth muscle atrophy, and extensive fibrosis within the muscularis layers. So this is what differentiate a GI manifestation from the other system involvement in scleroderma. So there are few, how does it target the nervous system? It is not well known. Some of them have antibodies against the muscarinic receptor M3R, and binding of muscarinic receptors can cause all the signaling abnormalities and smooth muscle dysfunctions. But it is only seen in few patients, not seen in everyone. So that is not just the reason, but the reason is perhaps not much known. And what some people say that once there are few trials going on with in giving in IVIG for patients with a significant GI manifestations, and they say that based on the IVIG works more of like reducing the autoimmune burden and thereby improving the outcome. But it also just suggests that maybe the reason for it's an immune mediated neuronal attack rather than a direct fibrosis which is happening. So as we all know, there is an early disease window when there is florid autoimmunity that leading on to the before the fibrosis part. There are few patients who are at high risk. One is older age at presentation, diffuse cutaneous involvement, male sex, and presence of myopathy are especially not the fibrosing myopathy, the immune-mediated myopathy, and they are at increased risk of developing severe GI manifestations. And the antibody profiles, RNA-P3 confers a lower risk of GI involvement when compared to the AC or topoisomerase. So the clinical manifestations vary which part of the GI tract is involved. For example, when we start from the oral cavity and oropharynx, we know there is extensive fibrosis of the periorbital tissue. That is the reason why we get microstomia and the furrows we have, and there can be extensive fibrosis of the gingival tissue. Gingival tissue can go in for atrophy. There may be a periodontal ligamental widening. That is the reason why we have the inner teeth distance is widening, and the patient can have anterior pushing of their teeth. And the TM joint can also be involved significantly. It is not just the microstomia which is disabling the mouth opening, but there can be associated TMJ involvement due to the condylar atrophy and the TMJ arthritis. So the patient predominantly presents with microstomia, xerostomia, periodontal diseases, and predominantly in the oropharynx. So esophagus, which is the most commonly and affected in more than 90% of the patients, you can have problem with the esophageal motility and secondary changes due to the motility. So the upper 1/3 of the esophagus is striated muscles, and the lower 2/3 is the one which is autonomous. So it is predominantly involving the lower 2/3 of the esophagus. So the lower 2/3 of the esophagus has the muscle, esophagus per se, and the lower esophageal sphincter. So you can have problem with this motility can be due to the lower esophageal sphincter problems or due to the peristaltic abnormalities of the lower 2/3 of the esophagus. So due to the both the tone abnormality and the peristalsis problem, you can have significant acid reflux, the GERD, which can lead on to the chronic esophagitis. It can also lead on to Barrett esophagus. The peristaltic abnormality can predispose the patient for esophageal candidiasis, which is very common actually, esophageal candidiasis. And sometimes the patient with dysphagia can improve. You can give a trial of fluconazole in patients, especially if you look at the oral cavity and you see oral candidiasis, may not have that patchy white thing. Sometimes it may be just a bald tongue, a red erythematous tongue, which usually we describe in Sjogren's with candidiasis. Just like that, you can have just a bald, a glossitic tongue. So in such cases, you can even just give a uh, trial of fluconazole. The dysphagia may improve in such patients, and it is very common to have esophageal candidiasis in these patients. And then comes the stomach. Stomach has both motility problem and the vascular problem. So vascular problem is gastral antral valvular ectasia. There will be the so-called watermelon stomach. You need not necessarily have such watermelon stomachs, but you can have significant ectasias and bleeding from the ectasias. And dysmotility, just gastroparesis. The patient can present with early satiety, nausea, vomiting, epigastric discomfort, bloating, and it also attributes significant to the weight loss of the patient. The small bowel, the problem with the small bowel is unlike the esophagus and the stomachs, which we can easily access through an upper GI endoscope, or we can look with the minimal radiological examination like a Bayerian swallow. It is very hard to picturize the small bowel. That is one problem with the small bowel. And most of the problems in small bowel are mainly due to the dysmotility issue. So dysmotility issue which lead on to bacterial overgrowth. Some of them can have the things like blind pouch syndromes, and that is causes pseudo obstructions, chronic pseudo obstructions, hypomotility, bacterial overgrowth, and everything culminating into malnutrition. One specific thing that we have in a small bowel is something called superior mesenteric artery syndrome. So here, because in scleroderma, when the patient has significant rapid weight loss, the intra-abdominal fat loss is something which they can have. So if there is significant periduodenal fat loss which is happening, then the second part of duodenum can be compressed between the superior mesenteric artery and the aorta. So this will lead on to gastric outlet obstruction, the duodenal obstruction, and the duodenal obstruction will again lead on to can worsen the nutritional status and can lead on to further loss of intra-abdominal fat, and it's a vicious cycle of gastric outlet obstruction, SMA syndrome, gastric outlet obstruction, SMA syndrome. So this is something which you need to consider in all these patients with this refractory post. Most of them presents with the postprandial angina and postprandial vomiting. So this is something which you have to consider. For colon and anorectum, it is predominantly constipation, fecal impaction. Some of them can have colonic diverticulosis, pseudo obstruction because of the dysmotility. And anal sphincter problems causing significant fecal incontinence. And it will not be that the fecal incontinence of a neurology paraplegic patient. It will be very minimal, just the soiling of their underclothes, but it is so embarrassing for them that this is something which it adds to their social well-being. It's very much in them. They don't come up with the symptoms, but if you ask them, then they will tell you that it is the one which is embarrassing them the more, not the even more than the skin manifestations they can have. So this is something, although we can't do much for that, but at least we can try them with exercises and other things to help them out, and we can tell them about the pathophysiology, and maybe sometimes they may be able to get better care of these things. But fecal incontinence is something which you should be all aware of. So once we know that these are the symptoms predominant, and from the symptoms alone, we may be able to get to a point that okay, this part of the intestine is involved. So we know SIBO symptoms, significant dyspepsia, distension, chronic alternating diarrhea and constipation, abdominal distension, and significant rapid onset. Already they are losing weight, but there is a rapid onset of loss of weight which is happening associated with the multiple malnutrition components and all. Then we know that it is more often small intestine which is being involved. But if we have significant epigastric discomfort, bloating, and things like that, and maybe sometimes GI loss of blood and all, then we think more in terms of in small stomach. So our assessment and the GI disease is always starts from the clinical symptoms. We should have an idea, okay, this part of the intestine is more likely to be involved. And then comes a targeted approach. What we doing is to look for the anatomical issues that we have and the physiological problems that has arisen, that arouse out of the anatomical problem the patient has, and then affected regions and abnormality. And the scopies are one thing which can help us a lot, but we can split them into, if you have predominant symptom of esophagus, the one thing which can help you is we need to know the motility abnormalities and the lower esophageal sphincter and the reflux also we have to look for. For that, we can use an upper GI endoscopy. Sometimes it may be very difficult. Their mouth opening will be very narrow, and getting an upper GI endoscopy in long-standing scleroderma is very difficult. In such patients, we can also go for barium solo. This barium solo also help you to identify some of the ulcers, strictures. Even esophageal reflux can also be picked up in barium solo to some extent. So upper GI endoscopy, barium solo, and high resolution esophageal manometry with pH monitoring for looking at the problem with the peristalsis and the lower esophageal tone abnormalities. For stomach, main problem is gastroparesis and the vascular changes. So for gastroparesis, you need to have gastric emptying scintigraphy, which uses tagged food and looking at the movement over a time period, which is being done, gastric emptying scintigraphy for motility. And for vascular changes, you just have to do an endoscopy examination. Sorry. For small bowel, the predominant things are motility abnormalities. You have, in addition to the motility abnormalities, you can have lactose intolerance. Sometimes an overlap with celiac disease is also well known with the scleroderma patient. So, how do we assess the motility abnormalities? There's something called orocecal transit time, OCTT. So, you give radioactive thing, food, tagged food, and then you assess its movement through the intestine from oral to the cecum, and you get an orocecal transit time. You can also do breath test, hydrogen breath test, whether for lactose intolerance, you use lactose with tagged hydrogen breath test. And for oral transit time also, you can use glucose, tagged glucose, because once it reaches the end cecum, there is the bacterial growth, and then or whenever there is an outpoachings or a blind sac, and if there is a SIBO part, then there will be increased utilization of this tagged glucose, and you can detect it in your breath. So for if the patient is lactose intolerant, the lactose will not be cut into it, and the lactose goes into is not absorbed, will go directly to the distal part where the bacteria are more, and they will utilize this, and you can detect in your breath test. So lactose breath test for lactose intolerance, and glucose breath test for orocecal transit time, and SIBO assessment. You can use both. Then radiological investigations like CT scan can also help you to identify SMA syndromes, to identify pseudo obstructions. You can identify the blind outpouchings. You can identify diverticular diseases. Everything can be identified in a contrast enhanced CT of the abdomen. For lower bowels, you can get an endoscopy done, or you can use, even for small bowel, you can use capsule endoscopies, but the problem is they can get stuck in between, and if there is a significant motility abnormalities, it may pose a difficulty in the transit one. For anorectal problems, you can have anorectal manometry to assess the pressure changes that are, and to evaluate the sphincter function. There are few patient-reported outcomes that we can use, especially for studies and all. One is UCLA Scleroderma Clinical Trial Consortium GIT's 2 score, which is a 34-item instrument which divides there are 7 domains which are being looked at, and or total 34 items, and they are being scored from 0 to 3 in some of them, and then total score is divided and an average is being used at the end. They look at the reflex, the blotting, fecal soilage, diarrhea, constipation, social functioning, and emotional well-being of the are the domains, 7 domains which are being used in UCLA. And there is a 60-item larger one, which the promise one has NIH promise score. So that can also be used. Both of them are patient-reported and self-reported one. So you just have to give the patient the proforma to fill. So once we recognize that there is an GI involvement, once we recognize that the area of involvement, the extent of the involvement, and the severity of it, like we always do the complete blood count, we look for the hemograms. Are there any anemia, what sort of anemia it is. Sometimes severe malnutrition can be recognized from lymphopenias, or sometimes low triglyceride level, and you can get it in severe malnourishment. You can also have a low urea in malnutrition. So LFT, you look at the globulin levels. Sometimes hypergamma can also seen, hypogamma can also be seen in such patients. And so looking at all the pictures and doing necessary invasive and non-invasive investigations, you can have a reasonable estimate of the burden of the disease and involvement. So once we know that, then we go for the treatment part. Treatment part, non-pharmacological and pharmacological. Non-pharmacological has actually holds a significant chunk of the treatment protocols. So in order to prevent, if there is a reflux disease, the first thing to do is change your diet. You have to have a small frequent meal. You can tell the patient that your stomach is fibrosed and the volume that it can actually contain is low. And if you give more, the chance of pressure building up is more, and that can reflux back more. So you just ask them to have very small frequent meals. Uh, and you should ask them to eat things which are easily digestible. Avoid the things that can worsen the reflex, like coffee and chocolates. We usually ask them not to get milk, extra milk, because most of them are lactose intolerant, and that milk can also worsen their reflex. So they should take small meal, frequent meal, and after the meal, it is always better to walk a 10 minutes. Just a simple walk within the premises, within the house itself is good enough. Walking a bit will also enhance the motility. So always avoid eating 3 2 hours before the bed, and you can elevate the head of the bed 6 inches instead of just using a pillow. Rather, it is always better to elevate the entire head side of the bed using some wooden block or something to around 6 inches, not too much also. Then for SIBO, you need to have significant nutrients in your diet. You increase the diet and you also have proper hydration. For microstomia, you can have some stretching exercises for that. For anorectal incontinence, you can use pelvic floor therapy with the biofeedback. So one specific condition is, as I mentioned, SMA syndrome, where you have rapid weight loss, and that the cycle, you have to break that cycle with you need to have weight gain. That alone will improve the SMA syndrome part. So you just have to try to have some weight gain for this patient. It's very difficult to get them to have weight gain, but we can try actually. So some tips that I can use is, when the patient has significant dysphagia and a recent onset worsening, you can better give antifungals fluconazole, and treating, even if you are not able to assess for bacterial overgrowth, it's always better to treat and see how it works. Avoiding milk is something which you can try. Maybe around for 2 weeks or 4 weeks, you can try avoiding milk and then ask the patient to see how it responds. And even though you can, the curd is something which you can give them. It helps actually for the probiotic component it has and the protein component it has. Eggs are something which these patients can easily take, especially the egg whites, and this is something that you can advise them to have. It will not worsen their GI symptoms also. And if you want them to have some weight gain, especially in SMA syndrome, and then you can try giving a high fat, but more of an unsaturated one. And even ghee is something which we can try in such patients, but sometimes it can worsen their reflux symptoms. But still, this is something which we can try on. And refeeding syndrome, especially if the patient is admitted with severe malnourishment and you are trying to rebuild the nutrition status of the patient, always keep an eye on your refeeding syndrome, because they are known to have refeeding syndromes. So pharmacological measures, predominantly the reflux symptoms, the dysmotility, you can for the one is suppress the acid, suppress the reflux, increase the motility. So you use for protein pump inhibitors, then H2 receptor blockers. And vonoprazan is a newer acid suppressant. It is meal independent. That is something which is a good thing about it. It is meal independent. It is more sustained acid suppression. The problem with acid suppression is, although it improves the clinical outcome and the symptom improvement to this patient, the problem is it can cause significant atrophic gastritis. It can worsen the nutrition status. It can impair nutrition absorption from the intestine. So it is actually a double-edged one. It can worsen other symptoms of the patient, and it can also worsen osteomalacia, calcium absorption. Everything can be a problem. So preferably, uh, if you want to give, try with histidine blockers like ranitidine, and then if not working, then only you go for PPIs. That is something. And for especially for reflux, GI, the one thing we can consider is giving the postprandial the like the raft ones, Insta raft and other things which forms and covering above the stomach, and then that reduces the reflux. It will not affect the acid secretion, but it gives a very good symptomatic relief for patients, especially for the reflux symptoms they have. So that is something which you can consider in such patients. Prokinetics, we all know. These are the medications. So there are things that are dopamine antagonist, or maybe the serotonin receptor agonist. Both ways, some of them are more onto dopamine antagonism, and some of them are more onto the serotonin receptor agonism. And one few drugs which we don't usually use, but which we can which are beneficial, include mirtazapine, which is an antidepressant agent. So also it's a selective serotonin reuptake inhibitor. So this is something which we can consider, especially for those patients who have an associated depression. And baclofen is also something which we can consider in such patients. One thing that octreotide is something more very severe, especially for pseudo obstruction and very severe malnourishment. Such patients, octreotide is something which admitted you can consider. Very severe patients, you can consider octreotide. For lower GI management, predominant symptoms: constipation, stool softness, laxatives, and secretagogues are something which you can consider, especially frucalopride and for refractory diseases. And octreotide, total parenteral nutrition for severe malnutrition when oral or enteral feeding fails. Always rule out, think about celiac disease superadded celiac disease in patients with the systemic sclerosis, especially North Indian population. That is something which, if we screen and we get it, then it is something which we can treat also, which can improve the outcome of these patients. So that is something which I have to tell in itself. So the future research directions: identifying and recognizing the neuronal attack, how it comes, is something which we are looking forward. Gut microbiome, yes, we know that a change in gut microbiome both ways. It may be the trigger can be the microbiomes, and the clinical manifestations and the outcome can also be very well modified by these microbiomes. So research are ongoing. And the biomarker, the role of immunosuppression in management, it's something which we always look up to, because none of the studies where cyclophosphamide or MMF was used to treat other ILD or PAH symptoms and all. But GI symptoms, there was not much benefit for the GI symptoms. So GI is something which is evading, nor the vascular drugs nor the immunomodulators are not working for the GI system. It's only the symptomatic relief that we are currently able to give. So that is something which looking forward in the future. So to conclude, gastrointestinal manifestations are something which is mostly underlooked, because we have other more important things to look, but it is something which the patient actually overlook. So they come up with more symptoms. So we have to look at it, identify it, recognize which part of the intestine is more importantly involved, look for the complications that it has created, and then we have to have a treatment plan in it, with significant stress should be given to the non-pharmacological measures, especially the diet modification, the lifestyle modifications, and selecting a proper prokinetic agent, selecting a proper antacid is also very important in these patients. Just writing out pantoprazole, pantod D is actually not going to help them, and especially for interstitial lung disease and all, because it can the GERD symptoms can worsen, GI symptoms can worsen the interstitial lung disease. So we all use PPIs extensively. So it is not that it doesn't have adverse effects. There are significant adverse effects. It can worsen the SIBO, it can worsen the nutritional support. So we need to be more cautious when we treat the GI manifestations of such patients. So I'll be happy to take any questions if there is.
Yeah. Thank you, sir, for such a lucid talk. There are few questions in the chat box. Question from Dr. Gayatri is there. She is asking about role of fecal calprotectin in scleroderma.
So fecal calprotectin is something, it comes from the neutrophil. So whenever there is an neutrophilic inflammation, fecal calprotectin is elevated. So what we can is we usually screen it for IBDs when there is an inflammation. In SIBO, I am not sure whether there is an inflammation associated bacterial overgrowth. That usually it is a blind black bacterial overgrowth. I'll have to check. Maybe it may be helpful in detecting there is an inflammation, but otherwise I'm not so sure of how it helps in. Usually we do it for recognizing bowel inflammation, and SIBO is more often an non-inflammatory and bacterial overgrowth usually. So
Yeah.
I will check it up.
There is question from Shivam. He is asking about how to treat anal incontinence in SSC.
It's a very difficult thing. First one is to you have to have a talk with the patients and tell them that this is the thing, and you don't have the psychological support itself, it can improve the patient outcome. Second one is exercise. Kegel's exercise is something which we tell the patient, like holding back the sphincter tone, increasing the sphincter tone, and regularly evacuating and avoiding things which can worsen the pressure, like if the patient has dyspepsia and the GI disturbances with the taking some of the diet like aloo or rajma, then they can remove such things and see. And the lactose intolerance, if because all these can end up in significant gas formation, and this is something which can irritate the fecal incontinence is irritated whenever there is a distension of the colon. So anything that reduces can help. So we usually say to patient, if there is SIBO, you treat the SIBO, you ask them to have exercises, and you tell them to avoid milk and see. If the patient has lactose intolerance, treat it. If the patient has some other GI, the dietary issues, you treat them. That may be sometimes helpful.
Yeah. Dr. Sunil Singh sir is asking about role of IVIG in GI manifestation, and there are any specific syndrome complex that decides the choice between manometry, ugioscopy, and barium swallow. Or all of these are needed.
So one thing IVIG, I told there are increased interest in IVIG for treating severe GI manifestations, but it's ongoing only. And as I told, it maybe that it targets the autoimmunity part. So in established GI fibrosis and all, how it is going to work is not known. But currently nobody is using upfront IVIG for the symptoms. Maybe some guidelines may come soon. For the second question, one, if given an option to do one examination, one investigation for upper GI, I will go for upper GI endoscopy, because that will give you, even a patulous esophageal sphincter can be seen in upper GI endoscopy. It will also give you an idea of whether there is an infectious esophagitis, like an esophageal candidiasis is also there. You can also see the vascular ectatic changes. Even it will give you an opportunity to do an argon laser coagulation if there is extensive vascular malformations. It can also give you some choice of interventions that you can also do. So that is something which you can always consider upfront. The problem is microstomia, patient difficulties in getting that. And if you think more of an dysmotility thing, then going for barium solo will give you a little more idea. But I don't think people will be going more, because once the symptoms will itself speaks most often. If you are not able to get an upper GI endoscopy, going for barium solo is something you can consider. And pH manometry and esophageal manometry, clinical utility, how much is the clinical utility is something, because it's not available everywhere. If it is there, you can, because sometimes we overtreat. As I told you, giving a PPI and domperidone is something which we always give, but sometimes we may overtreat such patients, and that can also lead on. So assessing what we are treating, the amount of damage it has already created is always good, but you don't have to do everything to start treatment. You can skip it also. But given an option, upper GI endoscopy will be the one thing which I always look forward for first.
Thank you, sir. There are two questions more which we'll take. Dr. Amruta is asking about judicious immunosuppressive treatment plus lifestyle modification versus escalation of immunosuppressive treatment in anti-synthetase syndrome with predominant GI involvement, with minimal limb muscle involvement and insignificant ILD. What is your insight about this?
So it's altogether little different when it comes to myositis. The GI involvement more of an vascular problem. So anti-synthetase is not a notorious one for to have GI vasculitis. We have other antibodies which are associated. But still, if there is a GI involvement, uh, before attributing everything to the disease per se, it's always better. Like we may be missing a cholelithiasis, which is already there. We may be missing an GERD symptoms the patient already has. So non-specific other unrelated things are always needed to be ruled out. And then, yes, if you think that the GI manifestation is solely due to the disease, which is very less likely, because GI vasculitis, if it is there, it will have its own symptoms and this one. So yes, there you can proceed with increasing the immunosuppression, but always ensure that this is disease related, especially in scleroderma. Yes, almost all the GI manifestation can be directly due to the disease per se. But in other CTDs, I will I will stop and see. Okay, am I treating? Am I looking at the same manifestation of the disease per se, or am I missing something? So I'll just look at it and then I will treat.
Okay. Thank you, sir. Sir, last question by Arvind. Arvind is asking about efficacy of tofacitinib in scleroderma patients with GI manifestations and also in skin disease.
So, so as I told, immunosuppression, be it whatever immunosuppression we have so far given in other system, it seems not so working well with the GI manifestations. As such, trials with tofacitinib, published trials are not there. We have few case series and a trial is ongoing for skin manifestations on tofacitinib. So we are expecting some data on tofacitinib in scleroderma soon. As such, there are case series as published cohorts which says that tofacitinib works well for the skin manifestation. This is something which you can actually try for especially when you think giving rituximab is not financially feasible, or giving tocilizumab is not financially feasible. And this is something which you can see because it's a broad immunosuppressant. It targets predominant cytokines which are also involved in scleroderma, especially the fibrotic pathway and all. So this is something you can consider, and if you have a response, you should have it in within next 3 to 6 months. So trying a method tofacitinib is not something especially if you think that patient has problem with buying mycophenolate mofetil, unless you should always start with the mycophenolate mofetil or cyclophosphamide and then see. But this is something which is upcoming. We having a reasonable response. Yes, we are getting a reasonable response, but which can be considered, but data not there, guidelines not specified. But it will come soon. Data will come soon.
Yes. Thank you, sir, for such a lucid talk today. Any question? Yeah, ma'am.
Digvijay, Dr. Adarsh, it was an excellent and comprehensive review.
Yes, ma'am.
Thank you,
I
ma'am.
think we should include the baseline GI assessment as a part of our workup of the patients of scleroderma whenever they have their first visit. As we are screening the cardiac system and we seeing the lungs, we are doing the 2D
Yes.
echo, we are doing the HRCT. We should have a comprehensive GI check at the baseline.
Yes.
Yeah, yes, sure, ma'am. We should be doing. The only problem is most of them are a little non-specific, and we don't. Even if they say the things we can offer is also a bit limited, and they will keep on. They will be more worried about the GI manifestations, and it will be little difficult in the clinic setup to convince them. But it will be wonderful if we can.
We can have a set of questionnaire wherein we can
Yeah, sure,
identify
ma'am,
who
sure.
are the patients who need it.
Yes, sure, ma'am.
that
If it
will
can be done, will be very nice to be done. Even that questionnaire we can use SCLT,
Yeah.
UCLS questionnaire is something which we can use. That is actually it's not that difficult, simple only. Patient can itself do that. And anyway, we have to, non-pharmacological measures we have to tell every patient. That is something which helps them.
Thank you, Adarsh sir, for such a lucid talk and just throwing a light on less known entities like superior mesenteric artery syndrome and all. Thanks, sir. Thanks, Smruti ma'am, and thanks, Gayatri ma'am, for moderating the session. So we'll meet next month on third Sunday. Thank you, everyone.
Thank you. Thank you.
Thank you.